I'm Dr. Dayanand, a clinical cardiologist and a physician practicing in Bangalore since more than a decade. Today, I'm here to give some latest update in hypertension. And all of us are quite aware about hypertension, that is high blood pressure. So, as per WHO, around nearly 63% of total deaths in India are due to non-communicable diseases, of which around 27% are attributed to cardiovascular disease, which affects 45% people in the 40 to 69 years of age. So it is a peak period of the population. And raised blood pressure is among the most important risk factors for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. If you see the statistics in India, the prevalence has also gone up to over 30 years to 38% in men and 32% in women from 29% and 28% respectively. So, despite that, nearly half of the population, or 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get proper treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. It's a Lancet study 2021. If you come to the International Society of Hypertension, which has released the ISH 2020 Global Hypertension Practice Guidelines, the inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. Optimal care refers to evidence-based standard of care, and whereas the essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The AHA and ACC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low risk adults, where there is no ASVD or 10-year cardiovascular risk is less than 10%, with stage 1 hypertension, that is blood pressure in the range of systolic in the range of 130 to 139, diastolic in the range of 80 to 89 millimeter of mercury, management starts with non-pharmacologic therapy. So if blood pressure remains uncontrolled at 3 to 6 months, then you have to consider starting pharmacologic therapy. So coming to another aspect, that is ARDS, especially during the COVID-19. So acute respiratory distress syndrome, that is ARDS, is a potentially fatal condition involving lung damage, and experts often associate it with a severe COVID-19 infection. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. So lowering systolic blood pressure targets down to 110 to less than 130 millimeters of mercury range substantially reduce the cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed to 26% of the composite cardiovascular risk. Findings from now a second major trial supporting a lower target could deny the guidelines, which even among US professional societies range from thresholds of 130 to 150 millimeter of mercury. With regard to prognostic value of ambulatory BP monitoring, that is ABPM, and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommended that diagnosis hypertension should not only be dependent on office blood pressure measurements, but also on out-of-office measurements, such as ABPM or home blood pressure monitoring. This is over a period of 24 hours. So 24 hours and nighttime blood pressure BP measurements were associated with greater risks of mortality and a composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurements for estimating cardiovascular risk. For every 20 by 30 millimeter of mercury increment of blood pressure measured at night, the risk of mortality increased by 23%. That is very significant. And the risk of cardiovascular events raised by around 36%. Again, a significant value. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend five classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination therapy is particularly highlighted to improve adherence to therapy and BP control. So therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE or ARB plus calcium channel blocker or diuretic. Since early 2018 July, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen, namely N-nitrosodimethylamine, that is NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhejiang, Hawaii, that is manufacturing site where the highest levels of contaminants were found, every day for 6 years in the highest dose. So every day in this one, so over a period of time, 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of around plus 6% of patients. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison with to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,750 participants experienced the primary cardiovascular outcome. An ambulatory BP monitoring was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for cardiovascular events was significantly improved for nighttime treatment when compared with the awakening treatment. So these are the recent updates about the hypertension. Thanks a lot for giving me the opportunity to connect with you. Thank you.